Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator.
Incorporated in my lectures too. For post-op is very important. The hygiene after that is very important, and you should know all about it. And there are a lot now, and then many people and many clinicians are talking about the tsunami of peri-implantitis actually in the modern dentistry, and all these because like we all focusing on to place the implants, remove the teeth, clean up the mouth, place the implants, put the prostheses, and then done. Well, actually, the real work starts after we deliver all these things in patient's mouth, and we need to put the patients on regular regimen and hygiene and make sure that everything is on the right path. So today, as we discussed, we're going to talk about implant-supported overdentures from treatment planning to execute it. But let me tell you about Loma Linda, because I had no idea where Loma Linda was when I was in Iran. And then Loma Linda is located in Southern California, and Loma Linda means beautiful hill. And if you look at the Google Earth, it takes you all the way down there, and you will see it's all the way to the east part of Los Angeles, and it's around like 60 minutes to downtown Los Angeles. And we are one of like 5 or 6 dental schools in California, in California overall, and we are a private school. And I was really fortunate and lucky to get into this program. I'm really happy with the program, and still enjoying prosthodontics. And it's been now 3-4 years that I'm teaching at the school. It's really enjoyable, and it's very rewarding. So, and this is our campus. The Loma Linda campus actually established since 1905 and officially opened as a sanitarium. So they first, like they were accepting patients, and then gradually they're building up buildings and departments, nursery school, medical school, and it was in around like their 50th anniversary, around like 1953, that they built up the dental school, and their first graduate students were graduated in 1957. And since then, they have trained a lot of like dentists, a lot of hygienists, and we have a lot of good reputation in dental field and medical field. And I'm proud that I'm one of the Loma Linda alumni, as well as I'm actually very proud of the dental school that I graduated in Iran. Okay, so today I'm going to talk about dentures, overdentures, advantages, treatment planning, biomechanics, trying to briefly talk about all different kinds of attachments, and I'm going to show some clinical cases and complications, and trying to make it, I'm going to try to talk a little faster to be able to finish the whole thing. All of you guys, as clinicians, have seen these cases, and we have no other option except either extracting or doing something else. When a patient comes to you, and the teeth look fine, but because of periodontal disease and because of like maybe hygiene, none of them are savable. And they're all, for example, in this patient, all the teeth they had mobility grade 2 and 3, and nothing was savable. And you can see the amount of bone loss. So as I mentioned, you can either go for complete denture, but it has some problems. Functional compromise, chewing efficiency would be lower than natural, like 1.4 to 1.6. And the speech problem that because of the bulk of the prostheses. Many patients also about the retention of the denture, which is also a major issue for majority of our patients, especially on the lower arch. And the aesthetic, for sure, like sometimes when the people, for example, in the previous case that I showed, they have like fullness of the lip or protruded premaxilla. So maybe denture would not be a great ideal. I'm going to talk about it more. However, other solutions would be implant-supported prostheses. So implant supported prosthesis, it can start from removable or kind of fixed removable with like bars or bar locators, or it can be like fixed solutions like all on four, all type of all on X type of restorations. So which one we should choose and which pathway we should take based on the patient demand, based on what you see in the patients. Remember, more complex restorations, more components, it demands more money and it demands more dexterity and it demands more thorough treatment planning. So maybe the least expensive one would be a bar locator, maybe, and then the more advanced one would be kind of like all on four restorations. But for all of these, you need to know that you need to address the patient's demand and patient's needs. If you want to specifically more about like overdenture, I would say overdenture is a kind of luxury for implant supported prosthesis. It has the good of both ends. Like it has the benefits of removable and it has the benefits of implant supported restorations. And it gives you a good patient outcomes because the psychosocial, functional, and anatomical features of the treatment and the patient. If I want to talk about the psychosocial, we can say like we are able to have a better aesthetic with overdenture in many cases. Why? Because, for example, as this case that you see that Dr. Charles Goodacre had done it, is not necessarily we can do full balance occlusion in these kind of dentures. Traditionally, we are taught to make the dentures in full balance, like in protrusive and like excursive, non-working, working, it should be balanced. But if you have some extra retention on any arches, for example, on the mandibular arches, that maybe you cannot be 100% on those kind of balancing rules that we would like to have. And you can play with the teeth, the position of them, and we can make them a little unbalanced and maybe give it like a more natural look. And patients will all happy with dentures because it brings some confidence for them and it affects their quality of life. It's been mentioned in different literature. And if you look at the systematic review in 2007 by Thompson and their groups, they show that it's interesting that in maxilla, the implant-supported overdentures were not significantly greater. It creates greater satisfaction or significant oral health improvement in patients. But in contrast to maxilla, the mandible, there's a compelling evidence that the patient were more satisfied with the implant overdentures. So that's why like there's some common, there's some they're talking about maybe a gold standard would be the having implant support overdenture at the mandible. And then some people say yes, some people no, but again, we all know like retentions on the lower arches are not always the easiest way to go. So if I talk about function, you will see that implants underneath the dentures can increase the biting force around 3 to 4 times more. Patient can get better chewing efficiency. And for example, in this patient, if you see, patient was wearing dentures for more than 20 years, and she could never have the luxury of having a bite on an apple. But as soon as we gave her the dentures and overdentures supported by implants, patient gave her an apple. An accident, I had an apple in my office, and then I gave it to her and I asked her to bite down and test it out. And we had some follow-ups on this patient later on. And in that case, that it helped the nutrition, it helps the diet, and again, it affects the patient's quality of life. And it's been shown when you have implants, although we know that we don't develop like nerves around the implants, but it can improve in kind of sensory and tactile sensation in the bone around the implants, gives like kind of like better sensation. We call it like osteoception. And for sure, their speech would be improved because we have better retention. Patient can pronounce words and words better, and they can confidently go to the public. On the other hand, some studies shows that by having implants underneath your dentures, you may have less bone resorption during years, and also because you have increased amount of like bite forces, that it can prevent muscle atrophy, especially and on the masseters. Now, briefly talk about removable, but you need to know like sometimes it's hard to find out like which one works best. Patients can afford like multiple implants, they can afford multiple implants underneath the mandibular dentures, And you may say, okay, so if the fine is not the issue, which one should I route? Should I go for fix, or should I go removable? Well, in that case, you need to do a thorough evaluation, because, like the removable, there are some advantages for that. It can provide some facial scaffolding, means like you can get some soft tissue and lip support for your patient. If you have some arch discrepancy, for example, severe class 2, severe class 3, you may be able to set the teeth a little off the arch, a little like playing around with the teeth positions. You may minimize the look of class 2 or class 3, or may bring the function, improve the function of the teeth and during chewing. Also, it has kind of improved hygiene, because the patient can take it out, easily clean it, put it back on, and they can see themselves what's going on underneath their dentures and around the implants. And you have a little more free hand in where to place the implants. You're not restricted by millimeters. Sometimes because of anatomical limitations, sinus, nerves, we can place the implants a little in different positions. So it doesn't have to be necessarily dead center of for example, a central groove of a tooth. And initial cost overall is lower for overdentures. But when you're talking about fixed restoration for, or any kind of type of restoration that we're talking, well, because usually they are cemented or screw retained, they have a better retention, and they're all screwed in or cemented in. So patients, they feel like they have kind of their own teeth. They can chew better. They have no problems regarding biting on sandwiches or having sticky steaks. And in long term, it's been shown that if you have fixed restorations and if you have a good hygiene, you may have less office chair maintenance, less cost imposed to the patient regarding visiting us and taking care of the complications. And I'm going to bring it up at the removable section at the end of the presentation. So for example, in this case, in those two top cases, you will see that these patients, they have a kind of protruded maxilla and mandible, and maybe kind of removable prostheses. If we don't do, after extraction, we don't do any alveoplasty, or we cannot do much, then maybe a fixed restoration would serve better for these type of patients. In contrast to the lower pictures, you will see these patients, they have unsupported lips and cheeks, and they have retruded lip support. And having a removable prosthesis with some flanges can bring out the lips and can help for the support of and can improve the aesthetics of the patient. So if you want to talk about the diagnosis and treatment planning of the implants, you need to know that we need to address all of these four during the diagnosis and treatment planning. You need to know about the aesthetics, hard and soft tissue evaluation. You need to know about your restorative aspect, which is a big thing in our part, and the CBCT analysis. So examination and diagnosis, we want to talk. So I briefly talk about lip and facial scaffolding. We need to know about the tissue prosthesis junction. So we need to know where is the maximum smile. We need to know about the incisal edge, and we need to make sure about the vertical dimension, the restorative space that we have. If any of these are compromised, we need to know where to correct it and make sure that we can deliver a good long-lasting prosthesis with, of course, a good maintenance protocol. For example, this is another patient of mine that for sure you see all the lips, they are retruded, retrognated, and you will see with some sort of dentures, you can make it kind of nice, straight profile in this patient, and you can bring a good aesthetic to the patient. Now, some people say it's really hard to know, should I go with the removable route or fixed route? It's kind of easy to do. So if the patient is already wearing a denture, or you're planning to give the patient the prosthesis, and you don't know removable or all-on-4 type of restorations, you can easily duplicate the denture, and then you can cut half of the flanges on either side, and you put it in patient's mouth, evaluate it from different angles, do some photography, show it to the patient, you evaluate yourself, preferably if the patient, they have like a lot of like beards or like mustache and everything, try to ask the patient to groom it better, or groom, when they come to office, ask them to shave it, to have a better judgment regarding this aspect. So that's one helpful tip that actually, this slides are, pictures are from Dr. Charles Whitaker. The other thing is you need to know about the tissue prosthetic, especially for fixed restoration is crucial. Some patients with removable also, they don't want to show that much of a pink acrylic. So we need to make sure patients in any like movements, lip movements or cheek movements, they don't show much. For example, in this patient, the treatment planning was like a fixed complete denture on the maxilla and overdenture on the mandible. See that unfortunately the treatment planning was not done right. The alveoplasty was not done enough, and they placed implant. And then when the patient smiles or does some funnel shaped expressions, you will see the junction of the prostheses. And definitely, I'll show some slides at the end, and you will see even for hygiene purposes, it's a terrible prosthesis. The patient cannot clean it, so they have to come more often to our department to get them clean. And the lower edge is removable. But you will see incisal edge on the other hand. Incisal edge is a very key element in making sure that we are on the right occlusal plane, and it helps us to get to a right video as well. How is, for example, in this patient, denture was made, and this is CAD/CAM dentures, one of my first cases actually, the full digital dentures. And when we made it done, like, it looks like all the furthest like a left picture in this slide. And you will see that I had to mark the edges. I asked the company to reduce the incisal edge and make the for furthermost right picture. So this is the final prosthesis. And why is important for us? Because it helps us to estimate the occlusal plane. It helps us to evaluate the restorative space. It helps us to see what type of teeth length and size we need to choose. It helps us to see are we have enough room to put our attachments underneath or not. And during these assessments that we usually do it at the vaccine trial, we try to make the ask the patient to pronounce some V and F and V sounds. As you know, if the incisal edges are too low, the patient pronouncing F sounds just like V, and if they're they have put like the incisal edges too much higher than it should, so the patient pronounce the V sound just like F sounds, because we don't have enough friction between the incisal edges or the lips. Also, S sounds are important because it helps us to assess the amount of freeway space or interocclusal space between the teeth, especially when the patient pronounce S sounds. And I had a patient that I set the teeth, and the interocclusal space was not enough. And when the patient wanted to pronounce S sounds, you need to see the whole facial feature, because when they pronounce S, none of the teeth or waxing should touch. And when they touch, the patient, they're going to have a hard time to pronounce S sound. And what they do, they just make a lot of like extra features on the eyes and their lips, and they really struggle to pronounce the S words rightly. So it's important for us to determine those, and it helps for aesthetics, phonetics, and vertical dimension at rest and vertical dimension at the occlusion. So the other thing that you need to know is that not all the patients are great for removable, or not all the patients are great for fixed. So for example, in this picture, you will see that we have firm mucosa, we have a good amount of keratinized tissue, we have good amount of keratinized tissue and ridges. So this is going to be a good ideal case for denture. And then on the other hand, if denture or overdenture works fine, but for example, this picture, you will see the ridges are flat. We don't have a lot of keratinized tissue, and the implants, only 2 implants, and we have a lot of movements and stability on the denture and the load-bearing tissue. And that's why in some cases, it's better to include more than 2 implants, 2, 4, sometimes 6 implants is recommended. 6 is kind of overdue, but it's still doable. And when you have like a narrow ridge, you need to consider that also, like the possibility of placing multiple implants. So in restorative space, let's talk about this section a little more detailed. We have different ways to evaluate the restorative space. There are some rulers. You can use like some clear rulers, where you can use these kind of massage rulers. You can put it at the ridge of the maxillary arch, and then evaluate the amount of lip movements at rest, at smile, and see how much tooth show you would like to have. You can also evaluate the lower arch amount of tooth show, and it gives you an idea where you want to put the teeth. Also, when the patient are edentulous, you can record the patient's movements. You can ask the patient to smile and ask them to talk to you to see they normally talk at kind of rest. Do you see the ridges too close or too far? You estimate how much space is left. And then when you proceed with the case, you have an idea, okay, I might be able to put some implants or some attachment underneath my denture. Now it comes to some detailed assessment, then you go to the cast. So you make impression. If the patient has existing dentures, it would be great. You can use a vacuum forming sheet over the denture, and then mount kind of these kind of cast and see which areas you have enough room. I'm going to talk soon about like the restorative space, and then see which areas are good. Another way is like you can use your wax frame and mount them and remove those wax frames and see how much room is left from the proposed occlusal plane. The other way is like CBCT analysis, and you can ask the patient to wear the denture. I will show you some slide how you can make your dentures visible in the CT scan, and then measure from the crest of the ridge and to the occlusal plane that you're planning. And also one of the other easy techniques is like you can make a putty index from existing dentures or existing teeth, and then do some perioprobe measurements and get to conclusion, okay, where to place it, or do we have enough space for all the attachments that you're planning to do. If you look at a study by Dr. Ahujo, hopefully I pronounced it right, and Dr. Cagna, 2011, they have classified in 4 groups regarding the space. They say if you have enough space around like more than 15 millimeters from the crest of the ridge to the proposed occlusal plane, you may be able to do any kind of restorations, like with bar, attachments, fixed complete dentures. But if you have like around 12 to 14, then Locator will work just fine, and you have plenty good amount of space. But if you go lower than that, like 9 to 11 or even less than 9 millimeter, possibly consider some pre-prosthetic surgeries, alveoloplasty, to put room for your implants and for attachment. And why it's important? Because we need to provide room for everything, because it's going to directly affect the outcomes of your treatment. If you have if you don't have enough space for your locators, your teeth and attachments, what happens is just going to happen like this one, that you have to bulk up your prostheses. So what happens, in some areas you're going to have thin acrylic, and those areas are prone to fracture. On the other hand, the patient may complain that, okay, I cannot pronounce well because I feel a bulge in my behind my teeth, and some phonetics, S sound, TH sounds, or D sounds, those are like those pronunciations that they're directly affecting the tip of the tongue or the lateral sides of the tongue. If you have like attachments there, they're going to be compromised. You're going to have some clinical challenge regarding maintenance, regarding showing through, and sometimes the aesthetic would be challenging because sometimes they show through the dentures and the patient, they don't like it. This is another good slide by my friend Dr. Aghatani, and he cut off the locators, and you will see clearly that you need around like 6 to 8 millimeter space above your metal housings of your dentures. And not only that, but horizontally you need to consider room, because many times we see that the metal housing, they're perf or they show through the acrylic on the lingual side. So for example, this is a weak point and you need to be aware of that. So in these cases, if you have no way around it, you have to send the dentures back to the lab. They will bulk it up, they reinforce it. I will talk later about it. So overall, we would like around like 10 to 12 millimeter space from the implant platform to the occlusal space. And these numbers come roughly about from these dissections that we need around like 2 to 3 millimeter for soft tissue attachments, 2 to 3 millimeter of space for the metal housing or cap, and we need the rest of it for the acrylic. And horizontally, we need around 9 to 10 millimeter of space. If you are working with bar, you need more space. So basically, the amount of space that is required to have like an all-on-4 type of restorations, you need to have more than 14 millimeter space. And again, these numbers coming from the soft tissue connections, the width of the bar, the attachments on it. So ideally, maybe sometimes you need around like 20 millimeter space from the implant platform to the occlusal plane. The other way around it, if you're going for the bar, you can ask the lab to set the teeth for you on the ridge, and then make a putty index and do the measurements, as you can see. This is a bar locator. You see, like we have put some locators, and you can see the putty index from the teeth, and you can evaluate those spaces, and then put the metal housing on top of it. And this way, the lab makes sure that you have room, and they will process it digitally. You can also do that, and you can have. For you designing the bar, you need to make sure that you have room, and they scan the teeth on the cast. They scan the cast, and then 2 separate scans. They superimpose and they measure it, and they design the bar, and make sure you have enough room underneath the bar, because we're going to have complications regarding the cleansability. So for CBCT analysis, you need to know that always, like, we start with like making a kind of prosthesis, because when you plan for implant placement in those locations, you need to know where are the estimated area like you want to place in. You cannot, I mean, freehand placement is okay in some cases, but it's not accurate, and it's not a modern dentistry. One of the ways is, like, if the patient has existing dentures, you can put some holes in it and put gutta percha, and then send the patient for CT scan with them in the patient's mouth. However, it's a kind of old school fashion, because you're actually destroying the patient's denture, and you don't want like to make it like a dotted perforated strain in the mouth. So other ways is, like, you can duplicate the denture. You can again make those fiduciary markers, and then send the patient for CT scan with the dentures in, and then you can see the bones, and you can also scan the dentures outside or CT scan and evaluate the locations of the proposed implants. You can make radiographic plate, and then conventionally you can just make holes that those are the areas that you would like to do, and then send it for scan. Hopefully I'm not that fast. Am I very fast, doctor? Are we on good pace? Anybody, you hear me? Okay, I don't.
You're doing great.
Okay, all right. Hopefully I'm not that fast. I just get to the end of my presentation. Thank you, Sable. Okay, so for CBCT analysis, you can duplicate. Let me go back to the previous slide. So you can duplicate the dentures in like barium sulfate teeth, and then send the patient for CT scan, and then based on the location of the dentures and the teeth, you can do your measurements and see, okay, do you have enough room or not. The other fast method, because I know like not all the dentists, they have the luxury of the lab in-house, or they don't have time to duplicate the dentures or something, you can use this technique. I learned it from Dr. Goodacre, and it's a very fast and efficient way to do it. So all those like old films that we have, like they have lead foils, you can secure it on the dentures, like the existing dentures, if they are well made, or if you think that they are the kind of okay regarding the teeth position or regarding the vertical dimension. Many cases they might be worn down, but it's fine. And then you can put them all adapted to the teeth and secure them with some wax, and then open up the embrasures, because when you want to look at it at the CBCT, you want to see which tooth, which area you're placing the implants. And then this is the result when they do the CT scan, and then based on that you will see. And you will see a line underneath those area above the bone. That's actually a PVS impression. So you can use blue mousse or green mousse. First of all, for 2 reasons. When you use these kind of material that they're kind of radio opaque, it helps you to see the soft tissue thickness, and you can kind of like evaluate the outline of denture. But also, many patients that they come to you and ask for dentures, many times if you're using existing patients' denture, they are not as stable. So they may like move, they may be loose, they may not give you an accurate position in patients' mouth. So we were kind of like relying with the wash impression or like with PVS impression. It doesn't have to be fancy. It actually makes it more stable, make it a little better secured when you do that. It helps. Some cases that are severely like flat may not help a lot, but majority of cases it helps for a better and more accurate prosthesis. This is another case. My friend Dr. Brian Goodacre did it, and you see like he took his time and adapted them very well, opened up the embrasures. And then this looks like a kind of like a golden smile or like silver smile you can give to the patient, and they can take a CT scan with it. And this is how it looks like. When you plan it, you will see how deep you want to have the implant, which locations, and you see in canines, clearly you see the canine area would be a great places to place those. And you can see the outline of these. Another method of doing that is like doing these speedy markers. They're usually used in medical field, medical radiology. They put those there. You need to put them enough, around like more than 5 to 6 all around the dentures, and you do a dual scan with that. So how you do it, you put the denture, you ask the radiologist to do the CT scan once outside the mouth. You can also scan the teeth, scan the denture. And then the other, and the second scan would be when the patient puts them in, put the denture in the patient's mouth or in his mouth. And then in that case, you can have them all scan. And then when you scan them all, you superimpose them together, and you can digitally plan. And you know that there are a lot of companies outside, and they do the digital scanning for you. And you give them, if you give them those files, they can even superimpose visually for you. They send you the preview for you, and they plan it. So you don't have to be kind of computer genius about that. So you just preview it, and if you like the location, you can make your surgical guide. And this is how you can see the buttons above it, and you can do. And you know, Evident, one of the companies that they make the digital dentures, they can also make you some surgical guide that eventually you can use it as a radiographic template, that you can eventually use it as a surgical guide as well. And as you see in this case, 2 implants were placed in canine. Conventionally, and I still do that, is like when usually like I do these scans just before the implant placement at the wax trial. So I do the wax trial, I make sure the patient likes the aesthetics. While the teeth bit the wax, I duplicate them, and I send them for CT scan. And then later on, if I see the locations are good, you can also use them as my surgical guide, or I give it to my oral surgeons to place the implant. And as you see in the lower right pictures, I mark those areas with Sharpies. So those are the proposed areas that I ask my surgeon to place the implants within the confinements of my denture, but in the locations of laterals or premolars. In canines, we didn't have enough amount of bone. And you can use it like that, and you can see in this case like some bone leveling was done. So aesthetics is important. So wax rims, when you adjust the wax rim, again, it goes back to vertical dimension, it goes back to teeth positions, and you do a CR record with those, and you choose everything, and you make sure that the lip support is good enough for you, and then you evaluate the smile line, and you can mark the smile lines. You know how high or how low you want them to be. And then as I previously talked about it, you can have your cast mounted and see where to place the implants. On the other hand, again, traditionally we're all being taught about a smile and then we mark it. But remember, we are human beings, that we are not only doing smile. We do a lot of like mocking, we do a lot of like gestures, and we make a lot of shapes with our lips. And you need to evaluate each of those and make sure in all of them, like you fully cover the prostheses and your dentures underneath the lips, and lips will hide everything for you, and you can do whatever underneath it. So This article in 2014 published from Loma Linda by Dr. Walter and their colleagues, and you can see like if we have Duchenne smile, we have some glimpse of disgust, so we can lift up our lips and you will see how much maximum tooth show you will have, or you can have a kind of funnel shape. I like funnel shape because it kind of like maximize the amount of like gingival displays, and you will know where to start from. And then at the end, you finalize your teeth setup, and then you do the festooning, and you make sure you have enough room, and you finish the job. And this is before and after prosthesis. This patient has overdenture on the maxilla with implants and a fixed complete denture on the lower arch. Let's talk about biomechanics a little. How many implants do we need to have on dentures? Where to place it, and what are the rotational axes that we're going to deal with? So I'm sure you might have seen implants with 1, 2, 3 implants supporting denture, up to sometimes 6 implants. But which one is better? So imagine we place one implant in one area, and you will see that if you place only one implant, what are you gaining? When you place one implant, you have rotations back and forth around the implant, especially if the ridges are flat. But with that, sagittally, you're going to have some rotations sidewise. And apart from that, again, you have mediolaterally some movement. So basically, with having an implant, you're not going to do a great service, because one of the primary reasons of having implant-supported dentures or overdentures is to bring stability to your denture, not only retention, but also stability. But if you imagine you want to place 2 implants, that's how it's going to work. When you have 2 implants, you're going to have a kind of fulcrum, and studies shows that with that, you will reduce some forces to the ridge and bring some stability to your prosthesis. So let's look at the 2 implant placement and overdenture. So anterior, posteriorly, you will see you may have some, because you have some fulcrum lines. So you cannot get away with that completely, although it helps and minimizes that compared to a natural denture. But sagittally, you may not have it, which is a good thing, and mediolaterally the same thing, because you don't have that much of movements. Where to place it, why we keep talking about like a canine or lateral positions, is because when you place the implants too far back in second premolars or molars, then you have a fulcrum line going all the way to the center, to the middle of the ridges, that line that crosses those. And in that case, then you have a 2 sides that the dentures can move all around it. And in that case, you're not doing actually great service. So in these cases, it's better to add 2 more implants, or at least 1 more implant, to have a tripod to make the dentures more stable. And when we're talking more 2 implants, we have some reasoning behind it. You know, we would like to have more than 2 implants when your maxillary arch is fixed dentition or overdenture or some implant supported prosthesis. If your ridge doesn't let us to place thicker or bigger implants, again, we recommend more implants. So when we are dealing with mini implant, definitely we need to have 4 or 5 implants. If you're dealing with short implants, it's better and it's recommended to place more implants. If you have a very poor tissue bearing surfaces or sensitive mucosa or high muscle attachments, it's better to place more than 2 implants. And if you have, again, poor ridges or patients with like more demand, or they have higher demand for retention, then I recommend, and we all recommend based on the study, that place more than 2. And bars can help too, but they have their own problems too. So overall, when we place 2 implants, you need to know you don't want them to place them too close. So if you space them out, actually it's going to be a better service. And it's been shown better general comfort, chewing, and ease of hygiene maintenance would be achieved by having them far apart. So have a better distribution. It helps for lowering the amount of like stress over the ridges. So imagine you have 4, then you're not going to have any AP anterior posterior rotations, you're not going to have any sagittal rotations, and you're not going to have any mediolateral rotations. So it's going to actually add a lot of benefits to the patients. On maxilla, it's a different story. The minimum amount that we recommend for implants is going to be 4, especially with when we say like minimal amount of implants, means like 4 3 and 2 is kind of possible, but it's not recommended. But many times we recommend more than 4. And when we recommend more than 4, it's like when you're dealing with a very low quality bone. And again, the same rules that applies for the lower arch, the same thing for maxilla. And because of the quality quality of the bone, it's been shown that if you have fewer than 4 implants on the maxilla, and then if you don't split them together, then in that case, you may have more failure rate and less success. And because of the force generated to all the implants unevenly, and then you will increase the chances of failure. So many times we add more also because we would like to support like some alien implants, which is very common. So where to place those 4 implants? Actually, in contrast to the lower arch, we would like to have our implants a little more posterior. Why? Because when you place 4 implants more anteriorly, you will see that, again, your fulcrum line tends to be more to the anterior, and you're going to have more rotations and more like rocking motions or swinging and pivoting actions around like the posterior part of the maxilla. But when you put them in the back and you have 4 implants, it supports them very well, and you're not going to have any rocking, any pivoting movements around those dentures over the ridge. And on the end, when you place them more posterior, actually they can be more parallel because we are not dealing with the inclined per maxilla, so it's easier to make them all parallel, and it gives us a good stability. However, we need to evaluate thoroughly with CT scan that we are not dealing with the sinus, we're not perforating them, or if you want to do that, then we may consider some sinus augmentation or sinus lifting in those areas. Do we need to place palate or not? That's another question. So let's see what we can do. If we have no palate, it's been shown that you're gonna generate forces, right? So if you remove them all, produce higher force to the implant and the surrounding one. But if you consider a palatal support, you need to evaluate it beforehand. You don't give any promises to the patients, because by cutting a palate in the denture and make the denture horseshoe, you're actually generating you're actually reducing the amount of surface area and generating more force not only to the tissue but only to all the components. And then you need to consider some metal reinforcement in your denture. You need to also look at the form of the arch of the maxilla. If you have a kind of good U shape and deep palate, maybe palateless will work very well. But when you're dealing with such a flat palate, you are dealing with actually more resiliency and more lack of stability on your maxillary dentures. So it's better to keep the palate in these cases. And unless like the patient like insists on that, and then you need to consider more and more implants to have this more distribution of forces. How far apart they should be? Studies shows that if you have less than 8 millimeter space between those implants in each side, then it's better to keep the palate. And if you have more, if you can space them out properly, so you have a better load distribution, then you can remove the palate. For the mandible, when we all talk about parallelism. Why is important? Because when you're there off angle, it's actually hard to align them with our components, and it might be harder regarding the maintenance too. The plastic inserts in it, they may wear more often, and gives you some hard time every time that they come, that they need to change the prostheses. They ask for the plastic inserts changing. You will see the retention is not good, and the patient, after a few months, they come back to the office and they said, "Doc, they don't snap anymore." And then this is not something that you want for your patient and for your practice, because all of these is chair time, and all of these take up your time, and the patient trust may be lower. So always try to have the implants in a parallel position, and make sure that they do a good hygiene regarding that. So the locations, the proposed location for maxillomandible would be within the sinuses of the maxilla and within the alveolar arch and the lower, if you're dealing with two. If you do it too much off angle sometimes, then you may need to customize your locators or make them in a way that the patient can easily insert in or not. Just like an RPD that you would like to have one path of insertion, you would like to have the same path of insertion for the implants. So again, in conclusion, if I want to say about the implant positions and implant numbers, it's better to maximize the distance between those. So in that case, you distribute the forces better, try to make them parallel so the wear and tear would be less for the attachments, and make sure that all the implants and the attachments they are confined into the denture base. So we don't want to just stick them out. So I'll show you a couple of cases and you will see that's nothing. So which kind of attachments you would like to have? So the individual ones, or the locators, or the single stud attachments, they're kind of very beneficial because they're less expensive and they need less space, interocclusal space. And it's been shown that many patients are happy and they have a similar satisfaction. But sometimes we would like to have them splinted. I will talk about it in future slides. We have different kinds of attachments. So some of them are called rigid non-resilient attachments. For example, the conus attachments, or like if you make like some custom abutments and then you make a metal framework on it that they are friction fit, they are custom, they are actually non-resilient at all. And then you generate all the forces to the implants and everything goes to the implants or the components. So they are very good for people that they have poor soft tissue or poor tissue bearing surfaces. And actually your prosthesis would be fully implant supported. Some of them you can provide it with 2 or 3 implants in the lower arch usually, and they are kind of restricted only vertically, and they can remove the support the around like 5 to 10. I would say you're gonna have load relief to the supporting implants. So you can still it's the kind of hard and soft tissue support, but still you generate forces to the implants, and the movements only like confined to up and down. We have like other type of like restorations, attachments like hater bar, and you're relieving some forces to the implants around like 30 to 35 percent, because you still have some rigid attachments to these rigid connection to these attachments, but you have some support from the soft tissue, so they're not fully tissue supported. And then we go for the double bar, again, more tissue support and less implant support. And then eventually we go to the rotary resilient or stud attachments that they are very free in movements, vertically or rotational wise, as I talked about it. And you're going to have a good amount of relief over the supporting implants. So the forces are distributed between the implants and the soft tissue. They can be locators from Zest company, ball attachments, or any other companies that I want to briefly talk about. Other attachments are kind of magnetic attachments. They can do any kind of movements, but they are the least desirable attachments that we can offer to the patients, because it's been shown during time, like the magnetic attachments or the magnets wear off and they lose their power, and they don't like sometimes fit, or they don't like connect strongly. So those are the least popular actual attachments nowadays in the market. So overall, we have all these kind of things, and you will see that companies, they make different attachments. All of them, they come in different dimensions. So you need to have in mind, so which attachments for which space is required. If I want to talk, for example, ball attachments, you will see that ball attachments, they require less space, but actually they need more maintenance, because the plastic inserts, they wear off more often. One of the very common locators or attachments is the one that's coming from Zest. They call it Locator, and they have some pivoting motions, and they snap better, they're bigger, and they have different kind of retention mechanism. There are some of them, they're called it like regular attachments or dual retention. With dual retention, which you get some retention from the plug inside the locator and from outside periphery. And they can compensate around like 20 degree if implants are off angle, so 10 in each side. But they also have another insert. It's called extended wrench, that it doesn't have the middle part. It doesn't have the plug in the middle, and you can like have more room for the pivoting up to 40 degree. They come in different tissue height levels, and the newest production line is like Locator RTX, and they're so proud of that because they say you can have up to 60 degree of off angle, and they have redesigned the metal housing. They redesigned the attachment on the implant, so you have more room. If you have like very severely off angle implants, you may be able to use those. What have they done in this in these new locators actually is they changed the coating of that, so it's a carbon nitride. Also, they used a kind of pink anodized housing, so if the acrylic over that area is thin, it doesn't show that much, and it masks and it kind of camouflage and blends in with the rest of the denture color better. And they had some extra double layering anti-rotational features in it, so they say it's improved, and it's they nowadays they use it very often in different areas. Another locator system which is very interesting, that is I think Preet makes one of those, and a pack of two of them is around like $270. And when these attachments comes from the alignments and then the multi-unit. Even if you have an existing multi-unit, you can get those attachments and you can screw on top of it. And this case, I will show you why they're beneficial. This case was having like a fixed complete denture on the maxilla, and the patient asked for a different prosthesis can clean it and clean underneath it. So in this case, in order to improve the hygiene and make sure that the patient is doing a good job at home, all the attachments, multi-units were removed. All three implants were selected, and then with multi-unit we make them parallel, and then we put the those type of locators on that, and then in that case they were all made parallel. And against it's good. However, there's one disadvantage, is like you need to have enough space. However, in these cases, there are fixed complete dentures. We have enough room, so there shouldn't be any worry regarding that. And this looks like you kind of, from something fixed, we made a denture that is kind of implant supported with 3 implants. For sure, we had to keep palate based on all the discussions we had, and all the ailing implants were buried, and we just put the screwdriver on it. Another system that I showed the picture is like Conus, is actually kind of friction fit cap. They go underneath the denture, but make sure you have some metal reinforcement. And they say like by the time actually you're going to have a better retention, because the attachments, they do fit better by friction, and they can tolerate up to 30 degrees of off angulations. There are some clinical pictures from their websites. There is another company, they make these kind of like a PEEK material. They come in different retentions, and PEEK is actually a kind of polymer, and then the pecton that they use for them is very wear resistant. They claim that they wear 2 times less than the regular plastic housings. The good thing about this system is like if they have off-angle implants, they have made kind of system different from what I showed you, that you can put them in and then make the implants parallel. So they have these kind of like jigs and plastic inserts. You make them parallel, you inject the resin and make them parallel, and then put the locators in, and that can the divergence and angulations of the implant and fabricate it. And then the top portion of it looks like this. So let's talk about different techniques to pick up the locators. I'm trying to go hit all the points and all the bullet points for the Overdenture. I know I'm talking a little fast. Hopefully you guys get a hold of me and you get everything. Like, we're gonna have some questions after that. So I think I'm gonna finish it within 5 to less than 10 minutes to make sure that I cover all the topics. How we pick up the locators in our prostheses. So there are different things you can do by impressions or direct pickup. There are some studies show that direct pickup is the most accurate way. However, you need to be careful regarding picking up, because when you pick up, sometimes you may not incorporate the metal housing properly. They may detach. So in order that, if you're using the old locators, you can make some grooves and make some retentions. So as literature looked at it, we have 18% of attachment loss. So if you make those grooves in the old systems, then you're not going to deal with that. You can also, although in the new system, they have some grooves, so it helps for the better retention. The new systems, we don't have that much of problem, but if you're dealing with the old one, you can also sandblast and paint them and make them retentive. What materials is good to pick up the attachments? You can use denture repair resin, you can use pattern resin, you can use Zester, which is a dual cure material. You can use composite resin, but make sure you apply the bonding, because PMMA and BCMA, all these materials, they're not percent creating chemical bonds, so bonding can bridge those material. There's another material which is relatively less expensive than others, is quick up, and it's dual cure too, and it has a good short working time. Other materials can be Bredent, and it can be a light cure or dual cure. They also work in different colors, but conventionally we do salt and pepper technique. So make sure when you want to pick it up, the page, you relieve the space, you put the metal housing over the implants, you put the denture in patient's mouth, and you those areas to make sure you are not altering the occlusion. So remember, occlusion should not be altered during the pickup process. So you put the patient's denture in, you relieve those areas, so you make sure patient with the metal housing and everything, they have enough room inside, so dentures are hollowed out. When you make sure you have enough room, then you start like salt and pepper or any kind of material that you have, put it inside those holes, and then put back a denture in, and make sure the patient bites down on it. I've seen this mistake in clinic a lot of times, that in order to pick up the dentures, they hollow out everything good, and then they inject the material or put the material inside the holes and put the denture, and they do a freehand. So in that case, you never know how much force you're generating and which directions. The tissues are resilient and they have some give. And in those cases, then you're going to alter the occlusion, and you never know. And when the material is set, it's too late. So you have changed the vertical dimension, you have changed the occlusion, the patient can never be happy. So then you have to go back and hollow them out again, remove it, and redo it again. So just be aware that whenever you want to do indirectly pick up impressions, do it in closed mouth technique. So after you pick it up, you just remove the excess material, and you can fill the voids with your material again, and make sure that you smoothen it very well. In this case, I did like direct pickup, but rather than making grooves, I sandblasted the locators. And this is how after that it looks like. And from inside, you will see the metal housing. It's been picked up, and then I put the plastic inserts in. In direct technique, it can be by impression. If you have your patient like this with locators, you can do your impression, border mold, and everything. And at the final stage, you can order the material, or can order the impression analog for the locators, and then do your impression with those. So you pick them up, and then you send it to the lab, and they will fabricate your prosthesis. If you're planning for making bar locators, make sure you do open tray splinted impression. You can do it in different ways. You can use this triad, cut them and connect them intraorally. You can use composite or any composite to connect them together, because they have the less amount of shrink. You can use like GC pattern, but make sure that you need to connect and reconnect, because up to 24 hours they may have some shrinkage. So you don't want any inaccuracy, especially when you're making your bar. You can also use your old burrs, your acrylic burrs, or your high-speed burrs, and you connect them with composite, and then do your open tray impression. In this case, that we did bar, and then we pour out the cast, and that's how it should be done. And then PVS for sure is the material of choice for these things. So why we need to use bar in some cases, especially in maxilla, because correct the angulation, because in premaxilla, especially if you place the implant more anteriorly, and because of like some anatomical limitations, then it's hard to have the same draw. So bars can help for that. And if you have poor bone quality, again, you can distribute the forces better and minimizes the lateral forces on the dentures and on the implants actually. So it has some benefits. And some patients, as I mentioned, that they have high demands, maybe more than 4 implants, and bars would be more helpful. And in those cases, we actually have an overdenture, which is kind of fully implant supported. Make sure that you have enough space between underneath your bar, because there 31% of the complication comes from hyperplasia because the patient cannot clean underneath it. It's important to maintain at least 1.5 to 2 millimeters of space underneath your bridge. We have complications regarding bone loss, as you see in this case, and you can see the fracture space is not enough. So you need to plan them ahead of time. You need to make sure that you don't have that much of cantilever and you don't have such long span bars, because it can fracture. And based on the literature, you have 10% of chance of fracture. So AP spread, if you know about the AP spread, is like, this is a kind of line that comes, imaginary line, comes from the center of the most anterior implant to the most posterior of the posterior implants. And you cannot extend your prosthesis or your bar more than this AP spread. So it's better to have it shortened. So in that case, you are not dealing with fracture or any other complications. The maxilla, the maximum amount would be 1 to 1. For mandible, if your opposing is denture, you can move for 1.5 times more than the AP spread. If you want to use these attachments, you can glue them so they don't come off, and that's how it looks like. This is another case done by my friend Dr. Swamidas, and these plungers that Dr. Curtis was talking about. And you can do all the digital design, and you will see that you can make them kind of like that. It needs a very good lab to make you these kind of prostheses. Complications at overdentures, it can be a lot. So you need to do a right treatment planning. Around 19% complications come from maxilla and 4% only on the mandible. So this is the whole list of these kind of complications, but always adjustments is like around 160% of the situation. So overdenture, if it's not done right, if it's not planned right, if it's not the right case selection, then you're gonna suffer from it. So make sure about your space, the maintenance, and the changing of attachments is very common, especially if the implants are off angle. So these are the complications we are dealing with in our clinics. The forces should be, the bite forces should be better to apply the forces around like the midpoint of the dentures and around like first molars. If you have those, it gives better stability. If you go more to the tuberosity area and then more occlusion in that area, because you have more thick tissue there, you have more resiliency, and it may interfere with the denture stability and balancing, and create a balancing occlusion. So occlusal adjustments, 18%, repairs can be up to 14%, and all of them comes from poor diagnostic and diagnosis and treatment planning. Make sure if you have like thin spaces, you need to reinforce them. Bar fracture is common. You don't want to see that. You need to reinforce with proper material, metal, or any kind of fiber reinforcement. Many people recommend metal, but make sure that if you are doing palatless, definitely you need metal reinforcement. But not necessarily all metal reinforcement works fine, because it's been shown even sometimes if you do the metal reinforcement, you may still like fractures. So that's how you need to know your patient's history. That's how you need to make the right balance occlusion. In this case, the patient was wearing like, he's a big guy with like big masseters and keep breaking the dentures. So in that case, maybe going back to CAD/CAM dentures and some metal reinforcement, bulking of the dentures would be the way to go. When you do the reinforcement for palate, even if you keep the palate, make sure your metal covers above the ridge, so you have a good support. This is a good case to show. The metals are all over the ridge, so you have a good reinforcement. For mandibular arch, the same thing. It's a kind of RPD design, but with good metal reinforcement. This is another case, so you can sandblast and then apply primer and the opaque layer or pink composite on top of it. It shows less, especially on the cameo surface. Some people use glass fibers or fibers. Actually, study shows those are better than metal reinforcement. It truly reinforces the dentures, and it can reinforce up to 2 to 3 times more. Not only that, they also usually colorless, so it doesn't show through the denture, and also they are lighter, so you're going to deliver a good service to the patients and with a lighter prosthesis. Make sure your implants are placed parallel, so in that case you're dealing with less amount of complications. And in this case, I think the implants were placed in 2 different directions, so 2 by 2 they were parallel. We decided to keep those front implants as is, just like on healing stage, and we just activate the back implants with locators, so we provide some vertical stability but also retention for the patient, as you see in this picture. If you don't follow the surgical guides, the implants can be placed off, and then that's how outside the box thinking come in. And if you're not within the ridge, or you don't have enough bone, you don't have enough keratinized tissue, that's how we're going to deal with it. So we don't want to see these cases in your practice. When the patients, they don't have enough restorative space, when the implants are placed wrongly, so they all come in place, and you have to deal with it. So for example, in this case that I previously showed you the case, we didn't have enough room, so what we did is just remove the prostheses, gave the patient some temporary dentures. The patient wanted to have some fixed restoration on the maxilla, so we cleaned up the dentures. We kept the framework. When I made a complete denture for the maxilla. For the mandible, as you see, there's not enough space, so metal housing was showing through. We had a lot of fractures. So as I explained, I made a new maxillary fixed CD with a more convex profile, so it's more hygienic. And for the mandible, I made another CAD-CAM denture with metal reinforcement, so at least it doesn't fracture. And knock on wood, so far the patient has not come back. This is a case that I put just to show you that locator is not only used for dentures or complete dentures, but also we can use them for RPDs. So in these cases, you just need to make sure you have enough room for your metal housing, and you open up the space for your locators and then you process the denture or set the teeth on top. Hygiene and risk assessment, as Dr. Curtis talked very nicely about, it's important. If you see your patients, they're coming with a lot of plaque around the healing abutments or attachments, take pictures, document it, and show it to the patients, and make sure you see them more often. Start from seeing them around every 3 months, then gradually when the risk goes lower, you can see them every 6 months or 1 year. So hygiene is important. You don't want to see plaque around the teeth, because these plaques are corrosive too, and teach them and show them how to clean the teeth with super floss or thick flosses or yarn or chenille, or anything that can pass underneath their bridge. Using soft brushes, they can dip it into Peridex or like a chlorhexidine or sodium hypochlorite or bleach with diluted bleach. It's been shown that it kills the bacteria and reduces the amount of bleeding and probing. As you can see, in this patient came to our office and had a lot of plaque. So after we cleaned them all with brush and plastic scaler, we got this result, took the picture, showed it to the patient, and we asked them also to go on sodium hypochlorite or bleach rinsing twice a week, and the result was really good. And the last but not the least, teach them how to clean their dentures. You don't want them to use bleach, especially with dentures with attachments. The bleach can deteriorate the plastic very well. Make sure that they clean the plastic inserts inside plastic inserts, and make sure they clean on top of their locator attachments too. If they want to use those denture cleaning pills, put them in, do it once a week or maximum twice a week, because those pills, again, they long term can deteriorate the attachments. Running water, soft brush with the running water helps a lot. And those are the easy tips that you can recommend to your patients. Make sure when they come for assessment to your office, make sure about the stability. If the dentures need to reline, do it, because if you don't do reline, you're going to have more rocking motions, and it happens, and all the forces goes into the plastic inserts and the implants, and they wear off more often, and they come to your office more. So be mindful of that one too. This is Chanel, and you can ask them if they have bar or fixed complete denture. You can teach them how to do it. They can buy a brand new one, clean them, or you can autoclave it for them, so make sure it's clean. Or some patients, they actually can use their shoelace. So get a shoelace, and then shoelace is a great thing to clean underneath the bars and all on 4 type of prostheses. And that's how it's important to have good hygienic space. So I think I finished it kind of in a good timely manner. Like, I finished within an hour. So hopefully I didn't go that fast. So I'm already discussions or questions for you guys.
All right. That was a very, Dr. Pooya, this should be in my library, This is something I should be turning to. I mean, it's for those who are in a program or still trying to learn about this stuff, this is like great resource, because this is what we see on a daily basis, in terms of what you need to do. So very well put. I don't think we don't have any questions right now. If there's any question, please come out. Let's type in your questions. If you want to ask your question, you can raise your hand. I'll give you permission to speak. But I think this is it's a guide. I was going to ask about, I know you did mention restorative space.
Mm-hmm.
So can you go back to the slide where you did mention, did you do any, where you talk about how much space you need, and if you need to do some bone reduction before?
So let me go back to that slide. Yeah, like it depends on what type of, again, attachments you're gonna pick. So if you wanna go for locators, you may around like 10 to 12, but 8 kind of is the minimum. So from the implant platform to the occlusal space or to the incisal edge. Okay. And these numbers coming from the attachments measurements. Again, know what kind of attachments you want to use, and then based on that, decide about the space that you have.
Okay.
And if you're using bars, they actually require the same amount of space as all-on-4 restorations, like fixed complete dentures. So you need to have more than 14 or sometimes like 20 millimeter from the crest of the bone or the implant platform to the occlusal plane, because you're going to put a lot of attachments underneath it.
So would you when you are trying to prepare the patient for, you will do that reduction at the time of implant placement, right?
Yes. And again, like having like digital planning is going to be a great tool nowadays, so we don't have to try and error. You can just make your dentures in wax rim stage, and then put those fiduciary markers or put like those metal bibs, yes, and then do the CT scan with those in, digitally superimpose, and see how much room you have for that. But you have to make sure your teeth setup is nice, or your teeth position are good for that matter.
So generally having a functioning denture that the patient is comfortable with is a good marker, or being able to say, okay, yes.
Yeah, it can be a good start to do. Yeah.
Okay. All right. Any questions? Do you have any? Sable, are you there?
Yes, I am, and I have a question.
All right.
Uh-oh. How are you doing, Sable? Long time no see.
Good, I know. I miss you, all of our implant talks.
Yeah, definitely.
Yeah, sorry my video isn't on, but in the middle of some stuff right now. But I did have, first of all, I really liked that shoelace thing that you put in at the end to tell them to clean. That's a really smart idea.
It actually came from a patient idea. The patient was not my patient, but actually the patient proposed that to Dr. Goodacre, and then he videoed it. So I said, like, it's going to be good to put it in my slides because it's really helpful.
Yeah, definitely. Just make sure you change the shoelace every so often.
Yeah.
But I did have a question. I do have a case right now that I'm in the middle of treatment planning, and basically she, for a very long time, has been wearing an RPD on the lower full upper denture, and she had more or less the teeth from like 20 to 28, but all of them were periodontally compromised. Needed to come out, but the way that her ridge is, you know, like a roller coaster kind of, you know. And so, you know, in my eyes, I was thinking, I'm like, okay, well, at least she has that bone from 20 to 28 where I can, you know, place the implants in. But if I do due to finances, you know, do the 2 implant overdenture on her, but do I just kind of, you know, fill where the valley is, you know, in the posterior with acrylic and maybe metal reinforcement, and that's the way that I'll kind of create some stability? Or do you have any suggestions? I'm hoping that kind of makes sense without pictures.
So let me rephrase your question. So you are planning to place some implants behind those teeth, are you?
No, so those teeth came out.
All gonna be okay. So you're gonna
so
just
yeah,
like
I want to
clean up the
them.
house.
Correct.
Okay.
So yeah.
And well, when you're having like these type of patients, to be honest, I first prefer to extract the teeth, maybe some bone grafts, and then let the tissue heal a little, and then I decided regarding the implant placement. But if you are really like based on the timeline, based on the patient requested stuff, you are sure that you want to have some delayed healed side. So we recommend putting it in canine area, but make sure you place them subcrestal and then submerge them. And if you're giving the patient a kind of immediate denture, make sure it's totally released, because studies shows like immediate loading on overdenture and everything is not a good idea. They have a highest amount of failure. Again, CT scan can help in these cases, but sometimes for immediate we don't do, because you already see the big socket in that. So I don't know if I answered your question right, but for metal reinforcement, we usually like to have metal reinforcement at least for people that they have a history of denture breaking or they have more than 2 implants.
Okay. So I did already take the teeth out, and she is healing. I did that about a month and a half ago, and I'm just, because of how the bone is, and I can just call you and talk about this later if you want. But,
no, it's fine.
But because of how the bone is, where it is so much a valley, where in the posterior there's no bone, and the only bone that really exists is in that area between, let's say, you know, 20 and 28. Yeah, that area. So I mean, I want to place the 2 implants there, but how do I fill in that area in the posterior? Is it just going to be a bunch of acrylic, and that's how I get that?
Acrylic, you don't have a lot of options, but you can also, if you can squeeze more than 2 implants or 4, or first of all, if the patient financially can afford it, do kind of fixed restorations, like all on 4 type of restorations. But you have no other choices except like filling those areas with acrylic and teeth. And then if the tissue is like so flat, and you, as I talked about it, if you're not going to get a good stability, rather than using 2 implants with locators, use bar. So have like 2 implants and a little more to the front, make a bar, connect them together. So bar, they get you more stability regarding that. And then you fill the rest. So those are kind of typical cases for patients that they keep the front teeth and they extract the teeth long time ago, and they lose a lot of support in the back.
Okay. All right. Thank you.
Sure.
Any more questions out there? But thank you so much. This was, you know, this is a truly classic presentation. I mean, that's why I see the pictures, the images, everything you use. You know, very, very well presented. I think it's
Thank you so much. But I was talking a little fast. The time was very limited, and I mean, all of us as a process, they have kind of OCD. So we want to just be comprehensive, talk about everything in a short amount of time.
And it's recorded, so we can go back and go back. We have to go back and ruminate on it and chew on it. But it's well presented, very well presented. For those who are in residency, who are in training, this is a very good resource. My classmates, I have to let them know. We need to bring you back. You know, when you said you were going to be able to reach out to the other professor to help us with photography.
I'll talk to him. Sure. Yeah. Why not?
Okay. I'll reach you during the week so that we can get that down. But I really, really appreciate this.
Yeah, absolutely. It was my pleasure. Thanks for inviting me.
I know it
was such an honor. And I enjoyed it a lot.
You've been up for the past how many hours? But it's been a wonderful time. Thank you so much.
You're welcome. Thank you. Thanks for having me. Have a great day.
Bye.
Bye-bye.
Bye, Sebo.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator